You literally stop people from dying or having worse outcome. So let's talk about it. What is TXA?
Yeah, so TXA or tranexamic acid scales in the coagulation anticoagulation cascade towards coagulation. That's something that's really important to note. You're not clotting the blood with this medication, but you are going to help improve kind of the clot stability with the drug.
All right. TXA.
Yeah. What would you like to know?
Relevant? Because it's coming. Let's do this as a good overview. So, yeah. I can start with, even though my opinion is meaningless, I think someone asked me recently if I could pick one medication to get in Ontario, what would it be? I was like, you're already getting it. It's TXA. It's an amazing drug, a safe drug, one of the best drugs we could probably get that actually has an impact on the grand scheme of things. You literally stop people from dying or having worse outcome. So let's talk about it. What is TXA?
Yeah, so TXA or tranexamic acid is like a synthetic lysine analog. So it plugs onto your fibrin meshwork the same way as that molecule in your bloodstream would, and prevents the breakdown of that clot. It tips the scales in the coagulation anticoagulation cascade towards coagulation. That's something that's really important to note. You're not clotting the blood with this medication, but you are going to help improve kind of the clot stability with the drug.
It supports clotting.
Exactly. Yeah.
Because that's key. Because they're like, am I going to cause strokes, DVTs, PEs if I give them TXA?
Right. And that's been a consideration for quite a while, but that's just not kind of what's been borne out in the data or in those very large, very well conducted studies on this drug, right?
Yeah, this has been studied very well, very rigorously in different settings, pre-hospital, in hospital. And one of the best docs in this area told me every minute in the Canadian hospital, TXA is given. Our medical counselor, and they're like, I prescribe it for menorrhagia all the time. And they're like, your 1 gram is not going to cause any problems when we give 8 grams for menorrhagia.
Yeah, it's really great to see it being used much more liberally for other contexts as well, right? However, in the pre-hospital context, what is it mainly validated for?
So the directive that's coming is for trauma, whether it's internal or external hemorrhage, just primarily for trauma, and it's up to each base hospital and medical counsel's discretion where they want paramedics to patch in for other types of bleeding. That's totally up to them, right?
Yeah.
But for us, preferentially, it's bleeding and trauma. But why is that?
Right. So that's where most of the high quality literature has been examined for it. So the crash trials showed that when a patient has a polytrauma, multiple disturbed blood vessels, right, which is you get hit by a car, it's not just one blood vessel that's broken. You have multiple sites of bleeding often, and a lot of bleeding throughout. So that puts you at a higher risk of trauma-induced coagulopathy, which is where you run out of those clotting factors, and then you're not able to maintain the integrity of those clots. And then as you disrupt kind of the procoagulatory, anticoagulatory factors, you will have more patients develop DIC and more bleeding complications later on, right? So that's why giving TXA helps preserve those clots that are already formed, helps keep those clots strong, and it helps preserve those factors later on for the patient as well, right? So there was the HALTED trial, which was randomized controlled trial, I believe, of TXA for esophageal bleeds, GI bleeds, and that trial was, I don't think, positive that way. So that's why we don't necessarily want to up front just give it for those types of bleeds and things like that, or brain injuries, brain bleeds. We're giving it for polytrauma, multisystem trauma. It's my understanding.
But do they need to have multi-system trauma together?
No, I mean just in terms of mechanism, right? We're not giving it for a patient that's been vomiting blood for an hour. We're giving it for a patient that has a traumatic mechanism, I should say.
Because if I do believe, and I talked to the specialist, esophageal varices didn't have any clinical or statistical benefits for TXA, and I will believe that. I'll quote the paper in it.
Yeah.
But interestingly, the indications and conditions are for it. You just need to be a little tachycardic, greater than equal to 110, or hypotensive. You don't have to be both. So you can see in a large body patients will meet this if they have a traumatic injury and hemodynamically unstable.
I think that's excellent because you're not waiting for them to decompensate and drop their blood pressure to give this medication, right? Which is amazing.
And they said those patients did the best. Like those that were like seemingly looked fine, but received it anyway because they met it, did better. Because again, we don't know what's going on truly internally.
Yeah.
And we support clotting. Because what is the leading cause of death in trauma?
There's a couple different factors, but like exsanguination. Yeah.
And do we have a lot of mechanisms or options to treat that right now?
No, like outside of your external bleeds and things like that, pelvic binders, those simple things. No, we don't. And we also don't have blood. So we definitely want to help, support the body's natural coagulation.
Yeah. It's like 40% of people that die from trauma have hypovolemia.
Yeah.
Which is wild. And 50% of them will die at the scene or before they get to the hospital, which is a pretty wild statistic too.
Mm-hmm.
But if we give them TXA,
yeah,
we can help mitigate their morbidity and mortality greatly.
Yes, 100%. I think another case that people bring up is like postpartum hemorrhage. So obviously we're giving oxytocin for that right now to help decrease the uterine tone, like kind of helping on the bleeding. But it has been tested in that population as well with the women's trial, and for that one it was positive. So that might be something that we could do later on, or do it with a patch, right? And these are going to be really critically ill patients that are also very complex. It could be, a patch point as well. But we'd probably want to stick to the medical directives here.
Yeah, and there's a reason why they picked it specifically for trauma, and if they want a patch for it. But like you said, oxytocin is the main drug we give for postpartum hemorrhage. Like, it's an amazing medication. It's the one medication we give prophylactically, to prevent them from dying, because postpartum hemorrhage is still the leading cause of death and morbidity. And I can tell you anecdotally, like just teaching in the scenario, they give oxytocin, like, all right, I'm going to pass for TXA. I'm like, what about the other maneuvers? Like bimanual compression, fundamental massage, like those are efficacious.
And I think that kind of segues nicely into where is this medication prioritized in your line of treatment? So just like you said, you're going to do those external maneuvers. You're going to give the oxytocin, you're going to do all of those things. You're not going to jump to TXA. So if a patient's sanguinating in front of you from a gunshot wound to their leg, you're not going to start an IV and give them TXA first, right? We're going to obviously do all of our basic high quality trauma care, and then we're going to give TXA after that.
Yeah.
So
but that brings us to the next point. Let's think about a very easy black and white answer. When we give TXA, then we'll add more nuances.
For sure.
So when should we give TXA?
I think en route probably makes the most sense for most patients most of the time.
Yeah.
So you have a patient that got ped struck on the road. You arrive on scene, you do your basic foundational resuscitation that you need to do. You go into the truck, you move, you start your line, give the IV TXA, or difficult IV delay, give the IM TXA. Right? I think that's most of the time. Now, obviously, there are complicating factors like prolonged extrications, things like that, where you're just maybe going to have to give it. You're going to give it on scene. But we don't want to delay transport. We don't want to delay other life-saving interventions in order to give this up front. But definitely should be within like your probably 10-minute window from your on-scene time. And I think that's very reasonable to expect.
It's key because, again, it's all contextual. Because what if they're trapped in a car? And I'm suspecting they're bleeding, they meet the indications? Yeah, give them the TXA.
Yeah.
And ideally en route, because one, you're not delaying transport. We know it's probably surgical in nature, but I can treat this in the meantime, which is awesome. Which route is more bioavailable?
IV.
But IM is almost the same.
Yeah.
Which is interesting if you look at the studies.
Right. No. So I think that's great. So we have like our first line is IV. So, like we talked about that chain of kind of like care for that patient. You hop in the ambulance. They've got a beautiful like AC that you can, takes you 40 seconds. You're good to go. Give it IV. Sure. Great. But, any delay, like you're going to have to fight for a bunch of different lines. Just give it IM. Right?
We think about the nuance. Those patients bleeding to death potentially, how do you think their IV sites are?
Exactly.
It's all contextual again. And how good is my success rate? It's hard to say. Experience, practice, situational.
Mm-hmm.
And yeah, like IV routes are most bioavailable, but the key is just to administer the drug in a timely manner.
So I guess in your view, based on this literature, based on this evidence, would you just give it IM first pass and then like look for an IV, do the rest of your care from there? Or would you at least try once for an IV kind of thing? I know it's like tough to put you in exactly this like binary decision, but Yeah, what do you think?
Yeah, it's hard because again, I'd look to see if they have any palpable or visible sites, but honestly, I wouldn't wait too long. I'd look, nope, give it IM.
Yeah.
Because it's been proven to be quite beneficial intramuscular. And the key is just to administer the medication. And I know it's quite easy for paramedics to say, oh, this is a multi-system trauma, TXA, but they're the ones that are like, they're low tachycardic. They have a traumatic mechanism. When they seem unstable, I don't know. It's like, yeah, they still meet the directive for a reason.
100%.
It's a very safe and effective, like one of the safest drugs we get.
I think one of the things that surprised me prior to us having it is to see how liberal physicians are with it in the ED.
Oh yeah.
It's like, oh yeah, TXA for like almost all the traumas we give. They give the TXA. So I think, just basing it on that practice that we've witnessed, being liberal with it is probably a good idea.
Yeah, and that's why we keep pushing it. Just administer the medication. It's safe. It's effective. It works so well, and you'll save lives. Like when paramedics end up saving lives, TXA is a very life-saving.
Absolutely, you can totally do the math. How many lives are going to be saved on a monthly basis with this drug?
So trauma season's come.
Yeah.
Let's look at the contraindications because everyone laughs. Like, would they know to have an allergy or sensitivity to TXA? It's like they give it fairly liberally in the hospital setting. They may have a sensitivity to it. Happens. Why can't you administer up to 3 hours of time of injury or unknown time of onset?
Interesting. So with all these studies, they had like the crash studies had time points for their outcomes of like when the medication was given. And if it's given before 3 hours, it has a really strong benefit for mortality. If it's given after 3 hours, that benefit kind of goes away.
Yeah.
So, most of our contexts, what we're lucky as paramedics is we're in the perfect position to give this drug within 3 hours on almost all cases. So I think that's why it's really good to have moved it upstream from the ED to the pre-hospital setting for us.
Yeah, it becomes less effective over time. The side effects may increase, even though it's relatively safe. But again, the main thing is that it becomes less effective.
Yeah.
So that's the key. Get in as soon as possible. And people are like, what do you mean time of onset or time of injury I wouldn't be able to establish? The example I always gave is, what if someone gets hit by a car, is found in the ditch like hours later? You're like, when have you been in the ditch? You can't establish that. That's why it's like it's probably not effective. It may lead to some side effect.
Mm-hmm.
That makes sense.
It's a really good point. Yeah.
Head injuries. Why can't we give it for head injuries?
Yeah. So that is one of the crash trials was just looking at isolated head injuries, and it did not improve mortality or functional outcome.
Yeah, and they categorized it crash study trial, I believe, to like mild to moderate head injuries, severe. And again, that's really hard for us to establish in the pre-hospitals. And if it doesn't show to have a statistical like clinical benefit, it's like, then no, that doesn't make sense.
Mm-hmm.
Okay. So those are pretty easy contraindications to remember. But the key is if someone has a head injury and broken pelvis or abdominal bleed or hemothorax, you still give the TXA. It's isolated head injury.
That's, I think, the key point, right? Because a lot of these patients are going to have head injuries. A lot of our polytrauma patients, it's hard to walk away from those without a head injury.
Yeah.
So it's not a contraindication to have a head injury. It's a contraindication to only give it for a head injury.
Yeah. Like you have an isolated head injury. You have to do the classic, someone slipped in the shower and banged their head. They got a hematoma and they're like, oh, my head hurts. I'm on Xarelto. And they're bleeding. Like we don't give it to them.
No.
But what if they are on blood thinner or Xarelto? Does that interfere with TXA?
Anticoagulants are going to obviously make you much more likely to have like these exsanguination like complications, but the TXA is not going to be like negated, and TXA is super beneficial for these patients. I know that was kind of a weird, long-winded way of saying it, but like you may have slightly attenuated bleeding still or coagulation still, but TXA will be beneficial.
Yeah,
absolutely.
TXA is still effective regardless of the medications they're on.
Yeah,
which is wild.
Yeah, it's excellent that way. Absolutely.
Yeah. So again, very safe, very effective in many different patient populations and circumstances. But our directive at this point, 16 years or greater, we give it to. Why is that?
That's just where the evidence base is.
Yeah.
Is in the adult trauma population for us.
Mm-hmm.
There's not as much evidence for pediatrics at this time.
So that's huge. Because again, that just shows the rigor of the evidence for the medical directives. It's like I'm sticking with the evidence this time at 16 years and older.
Yeah, so we're going to need, a crash style study of TXA in pediatric patients in order to institute that. Yeah.
Because intuitively, you'd be like, why wouldn't it work in peds? It's like we cannot assume that until we do it.
Yeah. You never know.
About safety.
You never know. It could have these like pro-coagulatory issues that we were kind of concerned with initially that did it from coming on board, right? So yeah, we just need more evidence.
Yeah. More randomized controlled trials in the pediatric setting.
Yeah.
And that's probably a hard study to execute because ped trauma, the ethics, the design is going to be very rigorous, expensive, labor intensive.
I think it's definitely a study that needs to happen,
Yeah.
right? Because leading cause of death for people under 18 years old is trauma.
Yeah.
So also at the same time, it's a very, it's a patient population that needs this type of care. We need more evidence to inform it. Like you said, the sample size is going to be potentially affected because you're looking at a narrow kind of end of the distribution in the population. And the complexity will be there from an ethics standpoint. It's also a little bit more complicated anytime we're working with pediatrics. In terms of like getting consent and things like that.
Yeah.
But I think, like you said, it's definitely needed.
All right. That's a perfect bridge into why don't we give it for traumatic cardiac arrest then?
Right.
Why not?
So in those cases, we want to focus on other life-saving interventions, which, are like high quality airway management, stopping bleeding, pelvic binding, chest needles, things like that. And so like I don't see the harm personally in that giving it to a trauma cardiac arrest. I think it's probably more we don't want to distract from other treatments. Maybe I'm assuming there's also like a lack in evidence of it being beneficial in patients that are in cardiac arrest. Like that'd be very hard to prove, right? It's like, oh, we gave TXA, we got more ROSCs in this population. I think that's probably the issue.
So it's like all of the above.
Yeah.
There isn't a lot of evidence. We don't want to take away from other priorities because it's no solutions, just trade-offs.
Yeah.
And talking to all the docs, like, by the time they're dead, they've probably bled out. And they're clotting so deranged at that point. Would it have an effect? We don't know.
It's definitely, it doesn't make sense as something that would increase your ROSC rate at all, right? You know that they've already assanguinated. What you'd need is blood, and those other life-saving interventions that we talked about.
Yeah. So, and we know we should focus on ABCs. Do they need advanced airway, basic life support? Do they need chest needles, pelvic binder? External pleats, right?
Yeah.
So that's why it wasn't intentionally put in for traumatic cardiac arrest, even though the leading cause of death in trauma is bleeding, because it's probably too far gone at that point, if no empirical benefit.
That makes a lot of sense.
Mm-hmm.
Yeah.
All right. So what else can we talk about with TXA? Ooh, how long should we infuse it?
So the like guidelines from the hospital were 1 gram over 10 minutes and then 1 gram over 8 hours.
Mm-hmm.
However, correct me if I'm wrong, that was moved to like we can give it over 5 minutes IV. And obviously I am just going to give it as an injection. But yeah, I think it's IV where you give it 5 minutes.
Yeah. The docs aligned the timeline with the drug monograph. So we infuse it over 5 minutes, whether it's push, depending on your base hospital, or if it's run in a 50cc bag. It's just given over 5 minutes because it can lead to transient hypotension and potentially someone that's already hemodynamically unstable.
Right.
If you look at the evidence for it, and all the docs say, they can't really say that's a strong side effect, but it's there just as a precautionary reason to match the drug monograph.
100%. I think that's something that we can operationalize pretty easily as well. So yeah, it makes sense.
When everyone says, why are we giving 2 grams? Isn't that where a lot of the research lies? Oh, so why are we giving 1 gram?
Well, so you'd give 2 grams, but over 8 hours. You'd give that bolus 1 gram, and then you'd give the second gram over 8 hours so that you can continue to kind of stabilize those clots and have like a steady state of TXA. So we're not going to give a bolus of 2 grams.
Mm-hmm.
Does the infusion make sense for us after that? Like giving an 8-hour infusion? I don't think that makes sense in most, land pre-hospital contexts. Maybe it's something that could happen later on, like just starting that infusion, but that's not really something we do typically, right? So
that's perfect. And the hospital can follow up, right?
Yeah.
So we give our 1 gram, which is incredible, safe, it's beneficial, and they can follow up with another gram over 8 hours.
Yeah.
But that's the key thing operationally, that we come to the hospital, say, hey, I gave TXA. They're going to be ecstatic, but you say, I gave 1 gram, because they know how to follow up after that. And one of the trials, actually studied what if we give 3 grams? Like in total, one patient receives 3 grams. There is no detriment to the patient. But it is beneficial to say to the hospital, I gave 1 gram, not 2.
Correct. Right. And we talked about this on another podcast. We were saying, like, the handover and things like that, and trying like the I missed ambo, or just at least making sure that you've completely discussed all the treatment that you provided for the patient and those details, right? Yeah, because those details matter and they make a big difference in terms of the long-term management of these patients.
Anecdotally, speaking with surgeons who deal with trauma, they're like, it's so hard to treat somebody that's coagulopathic that hasn't received TXA. They're so hard to treat because they're just bleeding, and they're so deranged in their clotting status. So it's like, I can only imagine. But also anecdotally, once TXA starts to render effect, it's like, wow, this is the extreme difference in the most beneficial way. So I was like, those are cool stories to take away.
Yes.
So I guess the best thing we're trying to hammer in, it's very safe. It's very effective. You will save lives. The key is just to give it. Just give it as soon as possible, whether it's ID, whether it's IM, whether it's on blood thinners, it will have a beneficial effect. And it's a very evidence-based medical directive. And I think it'll do wonders. Like, I think the study should be, you look at traumatic deaths in Ontario prior to the implementation to post-implementation.
Yeah, we could definitely extrapolate that that's going to save hundreds and potentially thousands of lives, in the next couple of years. And that's really exciting. I think that study needs to be done as well.
Yeah.
So,
yeah. And just looking not at the mortality rates, like what about morbidity?
Yeah.
Maybe decrease hospital stays, decrease healthcare expenditure.
Thank you very much for watching. If you have any questions or topics you want to see, just leave them in the comments. Respectfully, this is separate from our professional roles and responsibilities. We try to adhere to the highest quality of evidence and rigor, and this is all just education and support. Please follow your local medical directives and base hospital perspectives.